Greetings, this is Sandy Herek. This is class 715 with Professor Warren at Liberty University. I am doing the project on cognitive behavior therapy. For the sake of full disclosure, I will admit I have not intentionally implemented cognitive behavior therapy with any of the individuals, couples, or families I have interacted as a provider with. Again, I repeat intentionally. In Fordham et al. 2018, a proposal to synthesize and assess the reliability of the randomized clinical trials on efficacy of cognitive behavior therapy, they differentiated between high intensity CBT and low intensity CBT. In this proposal, they define high intensity as a form of CBT with CBT trained health professionals predominantly delivering it face to face in an individual group format, while low intensity interventions focus more on the patient's self help and they can be delivered by health professionals with very little to fairly comprehensive CBT training and can be delivered in several platforms like the internet, phone, paper based like worksheets, etc. So, for that definition, I might have been implementing CBT, the low intensity type, okay, in my prior experience. For example, while I was working at providing non clinical services that were deemed medically necessary, such as mental health supportive services or mental health skill building or psychosocial rehabilitation to groups or individuals with mental health diagnosis at a facility, I believe I was doing the low intensity CBT. The process will have been similar to what the process, I'm sorry, will have not been similar to what the video with the young college students and the therapist portrayed. Uh, it was much less intense. In this video, there was a clear progression through the session. It was very manualized. The individual is prompted to introduce the issue, and the therapist attuned every single time, well, since the beginning, she attunes by saying, it sounds like, and she states the issue as empathically as she can, which helps the individual feel heard and validated, which is an experience likely very long by the individual. Um, we all take for granted that we want to be heard and that getting that affirmation is actually a validating thing. So that took place. So whether consciously or subconsciously, we always want to be heard. So that's not to take for granted when the therapist was saying it sounds like she was purposely attuning and giving that necessary validation to reduce the stress. The session continues with prompts for explorations. The issues become organized through the same process of assertive listening by the therapist. So the individual, it looks something like this. It sounds like, and then the therapist occasionally will point out cognition dissonances, such you're laughing, but that's pretty hurtful. This is when the student was sharing that she was teased and bullied and called names for being overweight. That was very elegant, the way that she was able to present that dissonance in cognition, okay? Um, Towards the end, the therapist has already flushed out what it sounds like, okay? Contrasting what is happening, what the individual is alluding in the contradiction of what they really want, but they're not saying. And that is also very elegant because the individual is saying something, which is what the therapist is using as she's flushing out all those, it sounds like, but then she presents a suggestion of what the individual might be suggesting that it should look like, which is the contraire, right? Um, so at this point, um, the therapist, after doing this contrasting of what's happening and when the individual is alluding in contradiction of what they really want, the therapist moved forward towards firming up the goals that were lightly presented towards the start. Lightly presented. by asking the individual what things jumped at her that needed work. Then the therapist helps the individual prioritize the steps towards the objectives and the final goal. For example, the therapist finds achievable smaller steps, such as take this year to swoop into that independent college living life to death. Uh, and the needful steps that cannot be left unattended, such as the appointment for medication, particularly to address sleep irregularities, and the larger steps towards being able to discuss her feelings and boundaries with her parents. The therapists have been creating a CBT informed treatment plan segment by segment when the therapist will follow the it sounds like with asking the individual the question, what steps could you take to change this? Those are the tasks. In that, the therapist at times would suggest a change, how the change will look like. For example, when the explaining of how the development of the individual who's going to first year of college, it's correlated to individualization and leaving the nest or the cave, take whichever resonates with you. Or when asking when was the next appointment for medication review, and the individual stated a month away, and the therapist suggested that if it was a family member of hers who needed to visit with the doctor, she would like it to be done sooner rather than later. There was a strict pattern of attuning statements, the it sounds like, suggestions of how things should look like, and the invitation to the individual to reflect on ways to change it, with the implied assertion that the individual actually knows. When the individual states that they don't know, as the example was when the student said that she did not remember ever being relaxed, the therapist miniaturized the question to when were you relaxed for 10 minutes? There was an objection, and the therapist overcame that objection by demonstrating to the individual that there had to be a moment that she knew cognitively what relaxation looked like. Therefore, she knew it already cognitively. She had the cognition, the knowledge within her. And as all ideas go, if the idea is owned, it is likely to be acted on. And anecdotally, I will comment, I believe this was my strategy when delivering that low intensity CBT as the QMHP or qualified mental health professional, providing that non clinical service of support or skill building that was deemed medically necessary. The fact that I knew how to get the individual to own the steps or changes they needed to implement to achieve their goal of attaining independence and tenure in the community. That was the low intensity CBT type. On the other hand, as someone who moved from behavioral goals towards process goals, I did not feel that the same approach can be used on an individual who is experiencing PTSD from adverse childhood experiences, such as being sold by parents as a sex worker starting at age 12. The cognition that the individual is not what adverse things happen to them comes very short. What about when a person indulges in drugs to numb the pain? That they know they have to go to rehab is not enough. As the steps to get where they want to be is a good start. The acceptance as a cognition is a very good start to recovery, but it's not enough to be acted on when they issue a violation of safety by trusted figure in the nest, cave, take whichever resonates, or impulses that are created by a physiological desire that it's already neural pathways required differently because of the substance abuse damage to the frontal lobe part of the brain that addresses that part and all other parts of the brain impacting a person's self-control for impulses. The cognition is not enough. Um, Articles such as David et al. 2018 highlight that cognitive behavior therapy as its a gold standard. However, they clarify that this standard in reality is the best we have at the moment standard. To compare other models in terms of efficacy to it, what they're really meaning is that the standard is addressing rigor of testing such efficacy. There are limitations to this rigor of testing. because both David 2018 and Fordham 2010 mention one limitation, uh, and they both mention it, seems to be that the evidence is not clearly accounting for long sustained change, among other things, such as something called waiting lists, which they didn't expand that much. But like, if I go in a waiting list, what happened before I got to the actual time to come in and get my CBT done? Did I have any other interventions done? Something changed, so that couldn't be controlled. So overall, the video looked very similar to what I have studied and recently have read in literature about cognitive behavior therapy. For example, the American Psychological Association published in 2017 a one-page informational that listed four principles, such as problems caused by faulty thinking. Problems are, if only in part, learned behavior, and that better thinking causing new patterns of behavior will help ameliorate intensity and frequency of impairments and deficits resulting from the faulty thinking and associated learned behavior. In the scriptures, it said, do not conform to the patterns of this world, but be transformed by the renewing of your mind. Then you will be able to test and approve what God's will is, his good, pleasing, and perfect will. Romans 12:2. Just like the principles of CBT, it is the renewal of one's mind by changing faulty thinking with Holy Spirit inspired thinking that will help the Christians change the learned negative patterns of behavior collectively acquired in our original sins and inherited in our fallen nature into positive actions towards spiritual and physical change. Thank you for listening to my presentation. Have a good night, everybody.